It's a great pleasure for me to speak about the CCM Reg because it's one of the largest registries and it's with intriguing data. So I was surprised when I saw the data, when we wrote the manuscript and we had the results. I was simply amazed about the quality of data and the consistency of the data. Next slide, please. So this is the paper, the long-term clinical experience with cardiac contractility modulation therapy delivered by the Optimizer Smart System, mainly written by Daniel Burkhoff, Isho, Peter Falk, and the other authors there you can appreciate. So now speaking about the CCM Reg. So coming to the details. So first, next slide. So this was to assess the long-term effects of CCM delivered by the Optimizer Smart System on functional class, quality of life, and ejection fraction over 2 years, and mortality over 3 years in heart failure and cardiovascular hospitalizations. All in all, 503 patients were included, and they were stratified by their ejection fraction in low ejection fraction, indicated in red, below 25%, then a little bit better in blue, 26 to 34. And if you want, the good ones, the green, ejection fraction 35% or better. And they were also stratified in patients with atrial fibrillation and in sinus rhythm, which is a very, very important message later for the results. Next slide. Here you see the main characteristics. It's a busy slide. I don't like this kind of busy slide, so I summarize it in a very easy way. Mean age was 66. Most of the patients were male. Most of the patients had an ischemic cardiomyopathy. 75% had a defibrillator already in place. Almost all patients, or at least 80% of the patients had class 3 heart failure class. Atrial fibrillation was 36%. The mean ejection fraction was around 30%. And at that time, during the inclusion, people were at least on good medical, guideline-directed medical therapy, with 90% diuretics, IEDs, beta blockers, MRIs, and so on. Next slide. So for the patients with atrial fibrillation compared to patients with sinus rhythm, there were no major differences, except the people with atrial fibrillation were slightly older. They had less frequently an ischemic cardiomyopathy, surprisingly, and they had less defibrillators. So for the rest, there were no significant differences. Next slide, please. So these are the results for the entire cohort regarding functional class, quality of life, and ejection fraction. So we saw in the entire cohort that stable over 24 months, this was the endpoint, 24 months, there was a reduction of the functional class, of New York class, of 0.6 points. Then for the quality of life, there was a reduction of 10 points, which means in the Minnesota score improvement of quality of life. And we saw an increase in the ejection fraction in the mean of 5.6 points. That's stable, and stable until 24 months. It's not like we saw before in 6 months or latest until 12 months, stable over 24 months, and that's amazing. Next slide. So here you see the subgroups. You see the subgroups with ejection fraction, the red ones below 25, the blue 26 to 34, and above 35. And you see that also in the subgroups, there was an improvement. There was an improvement in terms of New York class. There was improvement of quality of life in all ejection fraction subgroups. And not surprisingly, even in the group with the ejection fraction below 25%, we saw the highest increase of ejection fraction over the time. So this was a major finding, because always when we were looking to the VO2 and so on, we always saw just the very good ejection fraction, 25 to 35, 35, better even than to 45. But looking now to these endpoints, we see that there's a massive increase in ejection fraction in this very low ejection fraction group below 25%. Next slide. Compared atrial fibrillation to normal sinus rhythm patients, we didn't see any difference. So it worked equally, either if the patients had atrial fibrillation or sinus rhythm, again, regarding the endpoints, functional class, quality of life, and ejection fraction, and also stable over 24 months. So absolutely identical results for atrial fibrillation and sinus rhythm. This was new. This was really striking new for us. Next slide. So people with atrial fibrillation, of course, they died, but they died when they had bad ejection fraction. People with ejection fraction below 25% died predominantly people in atrial fibrillation and better ejection fraction had lower mortality rates. So the main discriminator was not there, the atrial fibrillation itself, it was the ejection fraction. Next slide. So this is from my interim analysis already a couple of years ago from the registry, and we saw already, if you see the pre and post CCM event rates for cardiovascular death and hospitalization, we saw already a 70 to 80% reduction. So the patient was screened 1 year before and then 2 years after the implantation. If we go now to the next slide, we see exactly the same, and even we see something absolutely surprising and amazing. If you go through all subgroups, through all cardiovascular events, hospitalization rates, non-heart failure cardiovascular events, and so on, in the ejection fraction below 25, in the midterm ejection fraction, in the good ejection fraction, in sinus rhythm and atrial fibrillation, everywhere in each and every subgroup, we saw an improvement and we saw lower hospitalization rates. And that's absolutely amazing for me. Next slide. This can be translated in a 62% reduction, overall reduction in hospitalization rate for the overall cohort and for the patients in atrial fibrillation. The next slide. You can see the same rate. So reduction of 63% of hospitalization, I think this is a major endpoint for our patient. If you ask the patient to die faster or to live better with better quality of life and less hospitalization, 85% of the patients, as just a new publication will answer you, better quality of life and less hospitalization is much better than 3 months longer to live. Next slide. So for the mortality, after 3 years, we had to use a surrogate model. It's a MAGIC score. The MAGIC score is evaluated in almost 40,000 patients. It's a very easy score. Just some baseline parameters like age, gender, diabetes, comorbidities, and so on, drugs, ejection fraction, renal function, and so on, and to get an integer score. Next slide. You get an integer score, and the score will predict you the risk of dying within 1 year and within 3 years. This specific case, 16% risk of dying within 1 year and 37% risk of dying within 3 years. So it's very good evaluated from the ESC. It's a very, I think, useful score to have a surrogate mortality rate. Next slide. What we saw, we had a significant better survival than predicted by the MAGIC score for the overall group. Next slide. And this went through all groups. This overall group, this group with midterm ejection fraction, with a good ejection fraction, except for the group with a very low ejection fraction. So we saw people with a very low ejection fraction, they had a very high degree or a high increase of, or bigger increase of ejection fraction over time, but it didn't translate into better survival. So survival was not impacted by the improvement of the ejection fraction. So, but for the overall cohort and all the subgroups, it was significantly better than predicted by the MAGIC score. Next slide. So it's not the first data we have. We started a couple of years ago with the same. We made in our cohort with more than 80 patients the same. We calculated the MAGIC score and we saw survival was much better than predicted by the MAGIC score. This was repeated by the Seattle heart failure score 1 year later, also from a German group. And this is from Chuck Manu. Most of you know him for his echo trials and so on. And we saw this was a propensity matched group with a real control group. And we saw that also CCM had a better survival than the control group. This was the data so far we had before we had the CCM Registry. Next. Of course, there are some limitations. This is an observational, non-randomized trial. It's a registry. The ejection fraction was not tested at all with it. It was depending on the protocols of the the investigators. The changes in medication were not tracked. Of course, we didn't have the real mortality rates. We have a comparison with the MAGIC score, and the hospitalization rates were also compared to the hospitalization rates before the implant. So we didn't have a real control group. At that time, when the patients were enrolled in this trial, there was no approval of Entresto. So we don't have the data on that in specific. So this is not published, but it's on a good way to be published, I think. We also checked, because one of the main questions is always, is it like in CRT? Although in CRT it's not also like this. It's one of the errors. People always think that the non-ischemics are always doing better in CRT. It's not true. But to compare ischemic versus non-ischemics with ejection fraction and TAPSE left and right, we saw that the non-ischemics were slightly better. Doesn't mean anything. It's a small group with 160 patients, but we saw they were slightly better at that endpoint. But this doesn't mean that the ischemics doesn't work. We see the opposite. It works perfectly. Now coming to this indication circle, I would call it, because unfortunately, when we speak in US, we have this very small range. We have class 3, 24 to 45. So in Europe, we are lucky to have a broad range. We have the whole group of CRT non-responders, which we can use from the PIX-12 trial. We have the ejection fraction 25 to 45%. We have next slide. We have even the group now with lower ejection fraction, because I saw it already in 2002 and 2010 and 15. We always implanted because we didn't know better, and we didn't just focus on VO2. We implanted also patients with ejection fraction 15 to 20%, and they improved. And now we see with the CCM Registry that they improve at least with ejection fraction. This with a very low ejection fraction, they go higher with the ejection fraction and with the newer class. So for us, it's not an exclusion criteria, ejection fraction below 25%. So we have a huge range of CCM indications, and that's important for me. That's a very important message, because if I went to some conferences like 15 years ago, and I could tell them only we have a very small range, class 3 with ejection fraction of 25%, and that's it, then it became a little bit difficult. And now we have the running trials also for HFpEF. So I think the range of indications will be broader and broader over the time now. And now even in Europe, we are using it quite early in the treatment. We use it synergistically with the heart failure drugs. We fully believe in the heart failure drugs, but we see also if you make it synergistically and at the right time, it works even better, and you have better effects. Next slide. So for further discussion, the AF patients, we saw that they did the same good like the sinus rhythm patients. So there were no differences. If they died because they had a low ejection fraction, but it was not because they had atrial fibrillation. The procedure itself was the same safe, and the effects, the endpoints were reached in both groups equally. So as we said, the very low ejection fraction in the AF group was a predictor for mortality, but the improvement, the clinical improvement endpoints were reached in the patients in atrial fibrillation equally like in the patients with sinus rhythm. This is a great message, because we had some problems with atrial fibrillation. A couple of years ago, we didn't have the optimizer smart, so I had to smart out the box with David Pucci. David Pucci was a little bit angry, so we put a CRT not to stimulate on the right side. Then we made a biventricular stimulation. Then we blinded the atrial channel of the biventricular system, so it was blind. Didn't see the atrial fibrillation, so it started to stimulate. We stimulated with high amplitudes. The optimizer adapted the high stimulus amplitudes from the CCM atrial lead and saw its sinus rhythm and started to stimulate CCM. So this was a mess. But now with this algorithm, with Optimizer Smart, we see that it works, and we see that it works equally for patients with atrial fibrillation and sinus rhythm. That's absolutely great. Next slide. So as a take-home message, the effects for the mentioned endpoints, NUA class, quality of life, ejection fraction, this is stable and maintained stable over 2 years across a range of ejection fraction. For the overall and entire cohort, the cardiovascular related hospitalization decreased by 63%, and that's amazing. That's absolutely amazing. The 3 years survival in patients treated with CCM was better and significantly better than predicted by the MAGIC score. MAGIC score has its pros and cons, but it was anyway better than predicted by the MAGIC score through the subgroups. Next slide. So it's the end. You see again our old building here. We have there behind the new buildings. This you don't see, but even I find this part even somewhat nicer. So thank you very much for your interest, and I think we can overgive to Dan and to the question and answers. Will be very, I think, a lot of questions.
Thank you, Jürgen. That was extremely comprehensive and even provided the historical background for the why we pursued this registry study. In fact, why you pursued this registry study for so long. This registry was, I forgot the exact start date, but it's been going on for many years. And early on, even before the approval in the United States, CCM was approved in Europe for use. and we definitely saw the need to track long-term outcomes and effects in a practical manner. And that's really the utility of real-world registries, is to try to include everyone that receives a CCM device, and that was really the intent in the participating centers, that they would include everyone in the registry. There were no special tests done or extra burden on the patients or on the investigators. It was really just let's collect the data and report what was happening in the real world. So really, Jürgen's presentation really outlined really the main findings and the main features, and I'll just reiterate a few points so that we can get to questions and answers, which I think there will be many. But first of all, this is, at this point now, the largest real-world cohort of patients that have been reported on. It also is the longest duration of follow-up, and also it includes the largest number of patients with atrial fibrillation, which is obviously very, very important. The FIX5C2 study included, yes, it included AF patients, but there were very few patients, really not significant enough to make any real comments on the efficacy within atrial fibrillation, other than the device provides the same amount of CCM therapy when programmed properly in those patients as compared to patients with normal sinus rhythm. In addition, this has the widest range of ejection fractions in any registry that we have. And that is really critical, as Jürgen really correctly pointed out, in the United States, where our approval is 25 to 45, the lower bound of 25% was based on the peak VO2 results. And this is not, the be all and end all of of a index that gauges patient symptoms and how well they're faring from a clinical perspective. So this was to me, a major advantage of the of this registry, is looking at the lower EF patients. And I don't think this will change indications in the United States, but it provides important information for us from a scientific perspective in the United States, and I think also important practical clinical information for you in Europe. And of course, you saw that while there was no apparent mortality benefit in the lower EF range, we did see significant improvements in functional status and also reductions in heart failure hospitalizations, which is, as was already mentioned, very valuable in the minds of patients with heart failure. Furthermore, with regard to hospitalizations, in the randomized studies, the longest duration that we have is out to 6 months. And this now, by doing this analysis where we compare the rate of hospitalizations prior to a device implant to the 2 years, 1 and 2 years following the device implant, has emerged in the literature, not only in the CCM literature, but other literature, as a means of evaluating the effects of a therapy. You may be aware of 2 important studies with cardiomems where the same analysis was performed, one in the United States, one in the European registry, that showed the same type of analysis, and quite frankly, a similar kind of reduction in hospitalizations. So this is a very important, I think, very important piece of information. Again, looking across different subcategories of patients, the AFib, the normal sinus rhythm, and the lower EF groups, and also the higher EF groups. Finally, with regard to the mortality analysis, this is always a big question. Unfortunately, with with the rates of mortality that we see in heart failure hospitals and heart failure patients these days, really getting definitive answers about mortality is extremely difficult and requires very large numbers of patients in the thousands and long durations of follow-up on the order of 2 to 5 years. And that's what you see, of course, in the drug trials. You see large, very, very large thousands of numbers of patients and long duration of follow-up. So having the availability of scores like the MAGIC score and the Seattle score really provide us with an opportunity to get a glimpse at the effect of mortality, but maybe perhaps even more importantly, if nothing else, it provides important reassurance about safety. There is no, in any analysis that we've looked at, whether it's actual mortality, which is very low in the randomized studies, or in these analyses, looking at comparisons to risk scores, even in the lowest ejection fraction group, there's no evidence that CCM would have an adverse effect on mortality. And I think that this is a very important feature, especially if we consider CCM to be kind of within the realm of a inotropic form of therapy. Rather than, and that just leads me just to one final philosophical point, shall we say. Early on, CCM was compared to inotropes like dobutamine, milrinone, and levosimendan, where we know that there were increases in mortality. I think that everything that we've learned about CCM, including results from preclinical studies and molecular analyses of biopsies from patients who have been exposed to CCM that were performed by Christian Buder in Berlin, and also looking at now at these echo data that we have, everything here tells me that CCM is an inotrope in the same sense that long-term chronic beta blockers are providing inotropic support. With long-term beta blocker, in populations of heart failure patients with reduced EF, exposed in the earlier studies of beta blockers, we did see on average, 5 to 6 percentage point improvements in ejection fraction. And we're seeing the same thing with CCM. And by the way, it was the same thing that was seen with CRT. In the prospective studies, on average in a population, you see 5 to 6 percentage point improvements. And of course, there are super responders and there are non-responders as with every therapy. So CCM is really, I think, fitting very nicely into the spectrum of other therapies that we know that have been studied for much longer periods of time in larger cohorts, that they not only improve symptoms, but they also improve mortality. So I think these are my take-home messages from this study, and also I want to congratulate Professor Kuschyk for leading this effort for over many years, also with Professor Borgraffa, and I think this is a very important contribution, not only for CCM, but also for the heart failure community. And I think that was recognized by acceptance in really what I think now is the premier journal in heart failure, the European Journal of Heart Failure. This is really now the highest impact journal that is specialized in heart failure. So thank you for letting me have a few minutes to make some comments. And I think now it's time, I'll turn it back to George and Anja.
Thank you so much to both of you. Dr. Berghoff, this was an excellent comprehensive overview on how you see it and how this can be helpful to us. And thank you, Professor Kuschyk, for really presenting this outstanding and excellent data. So we are really excited about that. Before we want to hand it over for the questions and answers, I think there's one other thing which is important. We talked so much about clinical papers and the outcomes of those, but I think it's also important to learn how patients are doing who have the device implanted. And we have a couple of slides prepared. And Professor Kuschyk, it would be great if you can share your experience with your first patient who got the CCM device. George, can you advance, please?
So that's really an amazing case, and thank you that you give me the opportunity to present. We know from the fixed 12 trial that CCM works also in CRT non-responders. I never liked, and I promise you, I never liked this subgroup because I'm an implanter. I'm an implanter, a simple implanter. And when I see that I have to implant so many leads and have to explant them one day eventually, I'm not feeling good. So the philosophy is to get the hardware out of the heart, and we see it with subcutaneous defibrillators and so on, with leadless pacers, etc. So with a CRT non-responder, additionally with CCM, you have at least 6, and sometimes you have 7, 8, because you have some forgotten leads here somewhere sitting, but it worked for the all-time mentioned endpoints. It worked. It was an improvement. But next slide. I'm very happy to present you our very first patient from the year 2002. So and the amazing thing is he is alive. I just want to tell you already, he's alive. At that age, he was very young. He had an ischemic cardiomyopathy, myocardial infarctions. He had CABG. He was in class 3-4. You see the echo. He was lousy. Ejection fraction, he was on good medication. Ejection fraction was very low. QS was normal. But of course, we implanted him with a transvenous defibrillator. And at that stage with an optimizer 2. It was the first patient. I really remember him because I see him still every 6 months. An optimizer 2 in the year in November 2002. Next slide. The problem is with optimizer 2 you can't recharge. The optimizer 2 was investigational device for trials. So we had to change battery every 5 to 6 months. But the patient was, if you want, from 10% ejection fraction to 30% kind of super responder. He was also better from functional class. And after several changes of the optimizer 2, we eventually changed to the optimizer 3 because this was the first one which was rechargeable. And this was a nice device. It was red. It was with a shiny surface. I like that one. Next. So after so many changes, optimizer 2, optimizer 3, the defibrillator and so on, happened what it had to happen one day, infection, we had to extract and explant everything. And immediately, in the next 2 to 3 weeks, the patient suffered a severe deterioration, again to ejection fraction below 15% and class 3-4 symptoms. So the chest, if you see here, was empty, nothing more inside. No optimizer, no transvenous defibrillator, nothing anymore. Next slide. So we spoke with him. What to do with him. So we said to him, at least, first of all, with all careness we can do, we implant you a subcutaneous defibrillator because we are also very convinced from the subcutaneous defibrillator, and we very often combine it with CCM. So at least we wanted to have him protected again. But then after the infection, he came to us and spoke to us and said, I know I have a higher risk of reinfection if we implant some other devices again. And now to make a long story short, so we implanted him an optimizer 3 again, and he was again a responder. Then additionally, over time, he got a very broad QRS complex of 180, 160, 170, and 180 later. So we implanted him additionally also a CRTP. Next slide. So then, because he developed also atrial fibrillation, we had to change optimizer 3 against an optimizer smart. So it works. It works with all 3 devices. Although I said to you, don't blame me now, but I said to you, I don't want so many hardware. But you see, it works here also in atrial fibrillation. But the amazing thing is for me, I know him since the first day, 18 years. Now he's still stable with this combination of devices and of course the drugs on a good ejection fraction. He's stable on class 2 with no hospitalizations over years. And now the most striking point for me. This man, when he started with his career of heart failure in 2002, he lost everything. He lost his work. He lost his flat because he couldn't walk up the floors. When he lost his work and his flat, he lost very soon after the wife because she went with someone else. So meanwhile, over 18 years, he comes to us and he say he's of course not a super from the exercise capacity, but he's stable. He's stable on an acceptable level. He's happy. He has no hospitalizations. He has got a new work at the street kiosk, which sounds not perhaps so exciting, but he likes his job, and he has a kind of new girlfriend. So I think this is for us the story we want to hear at the end of the day. Not if the peak VO2 is 0.3 much higher or a bit higher or lower. If I see a patient like this, 18 years, who was at the end, and then in the middle he was at the end again, and then now after 18 years, in a heart failure carrier, he is stable, he can work on a limited level, and he has social contacts again. That is what makes me personally happy when I see him in the ambulance. Thank you very much.
Maybe I can make a comment or two. I think I remember the X-ray of this patient from many, many years ago with the 7 leads and whatnot. It was very impressive. To me, I was not aware of the long-term follow-up of this patient, and it recapitulates a story that I heard frequently from the early Optimizer 2 device that was non-rechargeable. And this was actually, these experiences were something for me in the very early stage that made me believe very heavily in CCM. Specifically, with the Optimizer 2, which had a non-rechargeable battery, we didn't know when the battery would run out. It had a lifespan that ranged between 6 months and maybe 12 or 14 months in some patients. And I remember very early on, patients with Optimizer 2, after 6 or 7 months, would come back to their clinician and say, I was feeling better, but now I'm not. And they would interrogate the device, and lo and behold, it was found that the battery had been depleted. And this is completely blinded. The patients had no way of knowing. The physicians had no way of knowing. So it was really a classic withdrawal, blinded withdrawal of therapy and reversion back to heart failure. So this is maybe some of you have heard of Koch's postulates in medicine. Robert Koch was a famous German physician who studied microbiology, but he pointed out a very important principle in medicine that if you give a therapy, to really know if a therapy is effective, you should give the therapy, the patient should improve, the therapy should be withdrawn, the disease should come back, and then you reintroduce the therapy and the disease goes away, or the symptoms go away again. And I think that's what we've seen here. So that to me is very very impressive and impactful. One question I have for you, Jürgen, it does relate to the leads, and maybe, you know, this is a very common question, and especially when you see this kind of X-ray that we're seeing here. You know, one of the several common questions about multiple leads relates to tricuspid regurgitation. And maybe you can comment from your vast experience now, you know, about the occurrence of tricuspid regurgitation in these patients.
That's a very common question indeed. So in this case, of course, we have a subcutaneous defibrillator, which is good. And for the rest, we have how many leads? 4 through the tricuspid valve. So of course, it's not good, but we can even measure some major regurgitations, but we never saw a clinical significance. We never explanted in all my 20 years now in this house, and I worked before in another house. I never had to explant RV leads or optimizer leads due to the fact that the patient had TR.
Yeah, I think that's very important. So what do you owe that? I mean, because it is, you know, massive and torrential or severe and torrential TR now. You know, leads are one of the reasons for that, and you ascribe that. I assume it's nothing specific to the optimizer. This must be true with your entire practice. So it must, is that related to the method that you use to implant the leads, the positioning of the leads, or anything special?
No, I don't think it has to do with implantation technique. most of the leads, of the RV leads, at least we place in the apicoseptal border. I don't place the leads apical. So it means that the septal leaflet of the tricuspid valve should be even more under stress. But we don't see this clinically. And even sometimes I think if I have 3 or 4 leads, I have less regurgitation than I have just 1 lead, which is pushing the septal leaflet.
Well, Professor and Doctor, as Antje said before, thank you so much for the presentations thus far. The good news is we still have 20 more minutes of your time. And I know Dr. Rao is on the phone as well. And he's invited, of course, at any time to offer additional comments. But why don't we go to comments and questions from the audience?
Yeah, thank you. Good afternoon. Congratulations on the publication. I'd just like to offer a couple of comments and see, I'd be interested in hearing your opinion. The number one is that you show here that the efficacy in patients with AF versus normal sinus rhythm really comes out to be pretty equivalent, but the observation is that patients in Europe get 7 hours of CCM therapy at least versus 5 in the USA. Could you comment on whether or not you think that would be attributable to the extra hours of therapy? That's number one. And then secondly, number two is the subgroup analysis of the EF. You show that in patients that have an EF of less than 25%, respond very well, but the patients with an EF of greater than 35% actually drop at the 12-month and 18-month follow-up. I wonder if you could maybe provide a comment as to what you think that's attributable to. Thank you.
So perhaps I can start with the first question with duration of stimulation. So we conducted here in Germany the fixed 13 trial. Only few people, I think, are aware of this trial. So we compared from 5 hours up to 13 hours because we wanted to see if there's a dose dependency or time dependency or whatever with different intervals, and we didn't see any difference. So if you stimulate 5 hours or 7 hours, the 5 hours were for the trials. It was trial protocols. Here in Germany, we stimulate 7 hours, but we are changing the interval sometimes if we don't have full amount of stimulation for whatever reason, for extrasystole or whatever. So we go sometimes to 7, 8, 9, or even 10 hours just to make fine tuning. But the stimulation amount, the time itself, it doesn't have any influence. Not in patients with sinus rhythm or with atrial fibrillation.
Thank you.
I want to make.
What about the second question, Dr. Kuschyk?
Sorry, I wanted to make one comment about the tricuspid valve issue. There was a nice publication of 328 patients a couple of years ago looking at CIED systems, pacers, ICDs, and CRTs. And the purpose of the study was to look at the prevalence of moderate and severe tricuspid regurgitation after implantation of these devices. What they found was that there was a statistically significant increase in the prevalence of moderate and severe TR with device implantation when comparing echocardiograms 30 days before to 12 months after device implantation. But the interesting thing was this was really restricted to patients with pacers and ICDs. CRT patients actually had a decrease in the prevalence of moderate and severe TR. The conclusion there was that anything that improves the forward flow, in essence improves heart failure, can be protective of the tricuspid valve. And I think that as we go out and we have this conversation with customers, that's one thing that we need to fall back on, is that in that way, CCM does draw a parallel to CRT, which both of which improve heart failure and LV pump function, and that is likely to be protective of the tricuspid valve. The PROTECT PACE study also looked at, the purpose of that study was to look at the effect of different pacing locations in the right ventricle. But what they did find from that also was that putting leads across the tricuspid valve didn't create moderate or severe TR. What created it was pacing the right ventricle. So if you look at those two things, then CCM is likely. So if you look at the FIX5, FIX5C studies, as well as the European registry that Dr. Kuschyk just presented, there's 651 patients in those three trials combined that have optimizers and concomitant defibrillators. So you've got 651 patients with 3 leads across the tricuspid valve, and we saw no reports of tricuspid regurgitation. Further, the complication rate is not different between patients with and without concomitant devices. So when we talk about the TR piece, we can fall back on two things that make CCM sort of not put the patient at increased risk of having moderate or severe TR. One is we don't pace the right ventricle, and two is we improve pump function and thus protect the tricuspid valve.
Thanks, Ishu. Professor Kuschyk, there was a second part to Gary's question, so I'm going to ask him to unmute and repeat that second part.
Sure, yeah. It was concerning the subgroup analysis of the left ventricular EF. It was the patients that were greater than 35%. It seems like they initially respond, or there's a change to the positive for the EF at 6 months, but then they go back down to 0 for a little while there, through till 18 months, and then come back over 24. I was just curious as to what you consider that to be attributable to.
So I think for the very low ejection fraction, it's clear. If you come from a very low baseline, you have bigger potential for improvement. For the higher ejection fraction, there might be several explanations. Perhaps then you have an idea for some.
Not really.
Improvement again.
Yeah, I think that, you know, obviously there's, as you saw, there's the standard deviations are relatively wide when we start getting into these subgroup analyses with smaller numbers of patients. You know, the point estimates will fluctuate around a bit. I don't think that would truly represent a decrease and an increase again. I think it's all, if one looked at a statistical analysis, it's really all within the constant within the bounds of the confidence intervals there. to say that, you know, it's not really statistically going down and up again. But clearly the lower EF patients have a greater room to improve, and I think that really, you know, explains why there's a larger impact in those patients.
Thanks, Dr. Berkoff. So we have another question from, I'm going to hammer the name here, but Gianluca.
Yes, thank you. Thank you for the presentation. Just I would just try to insert my question in this condition, in this context with the statistical analysis and statistical significance. I would like to raise the question if you consider the increase of ejection fraction in terms of 5 plus minus 8% at follow-up really clinically meaningful. And in addition, if you think that there is or there are some thresholds that can be addressed in terms of Minnesota Living Questionnaire or ejection fraction that can be really clinically meaningful and that can how to say set the CCM response for patients. I don't know if the question is clear, but just to be sure that it's something that is clinically oriented and not statistical oriented.
Yeah, I can start by saying that, you know, in the literature, first of all, for group averaged, as I mentioned already, if you look at older studies of CRT and beta blockers, the average improvement in the early clinical trials was about 5 percentage points. In literature, especially in the beta blocker literature that preceded, it was considered, there were studies that divided patients into responder and non-responder based on ejection fraction alone. And in those studies, they considered a responder a patient whose EF increased by more than 5%. As you probably are most likely aware, the responder, non-responder for CRT has become more complicated and multi-parametric. But I do believe even in those analyses, there is a EF cutoff, which I think is probably around 5%, but I don't know the exact, I don't remember the exact number in those studies. In terms of Minnesota Living with Heart Failure score, and also very similar with the Kansas City Cardiomyopathy Questionnaire, which is now taking over for the Minnesota Living with Heart Failure score in clinical trials. Changes on the order also of 5 absolute points are considered clinically meaningful. So we are, I think, if we look at the results, what we see here, I think we're more in the range of an average of 10 points. 10 or more points in the Minnesota Living with Heart Failure score.
Yes.
So just to be sure that it means that a patient that at follow-up shows an increase in ejection fraction of 5% and also a decrease of Minnesota Living Questionnaire of 5 points, it has to be considered a patient responder of CCM from CCM therapy. Okay.
Yeah, we haven't formally defined, we haven't made a formal definition of a responder and a non-responder. And I think, you know, there would be other, learn again, just following the CRT literature, there might be other parameters that might be considered, but I think in general, those numbers, I wouldn't make it hard and fast. You know, I think the most important thing, as Professor Kuschyk kind of outlined, is whether or not, you know, how the patient feels. Rather than put a number, you know, an arbitrary cutoff on these parameters. You know, patients going back to work, patients, you know, resuming social activities. These are really important things for the patients.
Okay, thank you very much.
Dr. Kuschyk, while we wait for the next question, I have one for you personally. So as a lead author of this article, what kind of feedback have you been getting from your colleagues?
I'm getting great feedback. We had a lot of discussions here in the hospital and all over Germany and internationally. So I think the most surprising for everybody of us was that it was consistently overall subgroups, and the improvement was anyway in the low, in the high, in the middle ejection fraction group, in the atrial fibrillation group, in the sinus rhythm group, and so on and so on. So that we saw an improvement in all and overall subgroups. This was a major point of discussion which I had over the last 4 weeks now, meanwhile, and we had a lot of very good positive feedback. As I say, it's perfect now, like we have good data like never, and they're reliable data, and we see improvement. We see important improvements in hospitalization rates and so on. And as Dan said, the pure cutoff, for me also it's not more so important like it was perhaps 10 years before. When the patient has a decrease in functional class, if he has an increase in ejection fraction, an improvement in quality of life, and if you want some exercise capacity also, I think that's good, then he feels better.
That's great. That's encouraging. Antonio, go ahead.
Good afternoon. Thank you for the presentation. I would like to ask a question to Professor Kuschyk. Professor, during your experience and your follow-up with the patient with CCM therapy, how many explant and extraction lead due to infection post implant of the second device have you seen?
For infection, very few. We had a significant, but I can explain it. We had a significant higher number of explantations due to insulation defects with the Optimizer 4. The Optimizer 4 of OS had a different surface, so it was a little bit scratchy. And there we had some insulation defects and we had to exchange the leads. With all the other leads and all the other devices, we didn't see any other explantation rates like with pacemakers. So the high energy of the high amount of energy, perhaps you might mention, which goes through the lead, it will not damage your lead earlier than a pacemaker lead. So only with one device, due to the surface, we had some issues and we had to exchange leads. And I would say for Optimizer Smart, if you implant an Optimizer Smart with 2 or even 3 leads, the rate of infection and the rate of lead insulation or whatever defects will be the same like in your pacemaker cohort. So your ground complication rates for infection and for other complications will be the same with Optimizer like with a normal pacemaker. So you can compare it with your normal pacemaker group and you will have the, I think, relatively exact number for your own cohort.
Thank you, Prof. Thank you very much.
So I will just ask Dr. Rao if he's got any kind of closing brief comments that he wants to leave with all of us, and then we can close down the presentation and wish everybody a good rest of the day. So Dr. Rao.
Thank you very much. Couple of comments. One is the question Rex asked to Dr. Kuschyk about what his colleagues think. I have gotten at least a half a dozen calls, just spontaneous calls from kind of key opinion leaders around the United States commenting on how great they think this data is. So kudos to you, Jürgen, for championing this article and getting it to the point that it got published in the way that it did, because I think it is compelling data. It is, as Dan said, the largest cohort, the longest follow-up, and the largest group of patients with atrial fibrillation. So this is a publication to put out front to really validate that the clinical trials that we did are important. Jürgen made a really good point. He said peak VO2 is great from a purely academic scientific standpoint, but real life data matters. And the anecdote he told about his patient who, now has a girlfriend, which is not a clinical endpoint that we have ever used, but perhaps is one we should start thinking about incorporating, because it is a life-altering one, for good or bad. But it is it's important. So this is a great publication. I recommend that everyone read it really, really well, know the pros, the cons, etc. As far as the the question that came up about the echo and the changes in echo, Angela pointed out that echocardiography was not mandated as part of a follow-up element of this trial. So some of the numbers start getting smaller because they were only done as part of standard of care. But the overall takeaway from this publication: largest cohort of patients with atrial fibrillation, longest follow-up, excellent results in all subgroups, including the atrial fibrillation subgroup, and the benefits in that lower than 25% EF group indicates that there may be something there that we can look at in the future if we wanted to move the U.S. indications. But again, Jürgen, kudos to you. Thank you for championing this. And then, of course, Dan has been instrumental in everything that's happened with Impulse Dynamics and CCM. So many thanks to you as well.